Next speaker is Keerthi.
So after ovulation induction, I am presenting how to optimize our IUI outcomes. So what is IUI? IUI is very basic procedure performed in the field of infertility. So there are three unique qualities about IUI. It's a very easy procedure. It can be easily performed by gynecologists and affordability. IUI saves the cost. It is almost 3 to 4 times lesser costlier than the IVF, and it can be easily affordable by the patients and with good success rate, mainly in cases of mild to moderate endometriosis and unexplained infertility. Compared to the expected management, IUI will give good results. So basically what is IUI is, it is direct transfer of the processed semen into the uterine cavity around the time of ovulation to increase the sperm density. So how IUI works? We are basically bypassing the cervix, better quality and more number of sperms are entering into the uterine cavity, and we are deliberately doing the IUI around the time of ovulation. So then semen washing, it will remove the detrimental contents like WBC and dead sperms. So if we perform all these steps correctly, then we can optimize our IUI results. First thing is the pre-treatment workup, then proper couple selection, then ovulation induction protocol, then careful monitoring of the follicular growth and endometrial development, then trigger, then comes sperm preparation, insemination and luteal phase support. So first coming to the history, in the pre-treatment workup, the basic investigation what we have to do is the ultrasound in the female. So we have to check her ovarian reserve. So if we are doing IUI for a younger patient is different, and for older patient it is different. So we have to check her ovarian reserve. Then ovarian reserve test like AMH, and for our success of the IUI tube should be patent. Then the semen analysis, the count should be at least 10 million on thyroid and prolactin. So in a female, ideally it should be less than 40 years. She is capable of spontaneous or induced ovulation. At least one fallopian tube should be patent, and then total sperm count should be 10 million with 30% of motility, or in the post-wash 3 to 5 million with 40% of motility, and there should be easy access into the uterine cavity with a negotiable cervical canal. So proper couple selection is important for success of the IUI. So in the male factor, males with ejaculatory dysfunction, erectile dysfunction and mild oligoasthenoteratospermia, that is around 10 million count, and if we are going for a donor insemination like azoospermia, or if the husband is not available, we will cryopreserve the semen and later will do IUI. And in the female factor like hostile cervical mucus, vaginismus or anovulatory cycles like PCOD. So and after that mild to moderate endometriosis and unexplained infertility. So in these two cases, so better to do ovulation induction with IUI rather than expected management. Treating younger women with good ovarian reserve with patent tubes, it has good success rate. With in older women with less AFC and patent tubes with adhesions, it has less success rate. So then if we are treating anovulatory disorders like PCO and male infertility or the unexplained infertility, IUI gives better success rate than if we are treating a patient of poor ovarian reserve, because in poor ovarian reserve, because of the poor oocyte quality, the success rate in IUI is only 8%. So these are the contraindications. We should not do IUI in these cases, like if there is active infection, cervicitis, cervical stenosis, blocked fallopian tubes, or the semen parameters are very much less, or in cases of stage 3, stage 4 endometriosis, poor ovarian reserve, age more than 40 years. In all these cases, it's not like we should not do IUI. So if we do IUI in these cases, because of the poor oocyte quality, the success rate of IUI is very much less. Then in male factor, like if the count is less than 5 million with morphology less than 2.5% and the motility less than 10%, that is in cases of severe male factor, will directly go for IUI, will directly go for IVF rather than IUI. Then coming to the counseling part. Counseling is very, very important in the treatment part. It also should be individualized. Why we are doing IUI procedure, what is the success rate, what is the cost and the complications, everything we have to explain. Like if you take a PCO patient, first thing what we have to tell her is, we don't know your ovarian response. In PCOD patients, sometimes the ovulation may not occur. In sometimes they might be delayed ovulation. So the daily patient has to come to the hospital, daily she has to take injection. So the cost of the IUI will be increased. And after that the risk of OHSS, multiple pregnancies, everything we have to explain in the counseling part. So this part has been already been covered. Then coming to the ultrasound monitoring. So ultrasound along with Doppler, if we use, we can increase our IUI success rates. So what is the importance of day 2? On day 2, we will see antral follicle count, we will rule out any cyst, and we see the endometrium, and we rule out any pelvic pathology. Then follicular size, how we measure is, we will take the mean of the two largest perpendicular diameters in the each follicle. Then we start the ovulation induction. On day 7 or day 8, again we will see the scan for dominant follicle. In case if we are using gonadotropin cycles, then we start from 6th day onwards. So these are B mode features of the mature follicle. A mature follicle is 16 to 18 mm in size, which has thin walls, regular round in shape, and it has no echogenicity in the lumen. A thin hypoechoic rim can be seen. Usually it develops 36 hours before the rupture. So these are the pre-trigger parameters. So follicle shows ideally 3/4 of the blood vessels covering at least 3/4 of the follicular circumference. The RH is 0.4 and the peak systolic velocity is greater than 10 centimeters per second. And ideally endometrium should grow up to 8 to 10 mm in thickness with vascularity in the zone 3 and zone 4, that is in the inner layers of the endometrium. And the resistance index is less than 0.5. So on ultrasound, if we see the dominant follicle of 18 to 20 mm with the endometrial thickness of more than 8 mm, we administer the trigger. So with pregnancy rates with 3 follicles is 37%, with 2 follicles is 26%, and more with 1 follicle is 7.6%. Beyond 3 follicles there is no substantial increase in the success rate, and we rather cancel the cycle. So this is the study showing optimal lead follicle size for HCG trigger in CC cycles. So HCG administration at a lead follicle size of 21 to 20 m is associated with higher chances of pregnancy, and in gonadotropin cycles it is 18 to 20 mm. Then coming to how we detect the ovulation. There is sudden collapse of the pre-ovulatory follicle, increasing the PODs, increase in the fluid in the POD, then luteinization. Then coming to the what is the timing of the IUI. There are two things that we have to remember. One is the sperm may remain viable for a period of 48 to 72 hours, and oocyte may remain capable of fertilization only up to 48 hours. So if we are going for a natural cycle IUI, we can perform IUI after 24 hours after the LH kit tested positive. Then in stimulated cycles, these are the ESHRE guidelines 2018 showing if a HCG injection is used, we can perform single IUI anytime between 24 to 40 hours. Then coming to the lab part. So proper semen collection is important for IUI success rate. Coming to the prerequisites. So at least 2 to 5 days options should be there. Laboratory collection is ideal. Then there should be no spillage of the sample, and we should not use any soap or lubricants. Then semen collection to the IUI interval. From semen collection to the sperm wash is maximum 30 minutes. And from sperm wash to the IUI, ideally immediately we have to do IUI. So from the semen collection to the IUI time is maximum 90 minutes. So these are the semen preparation methods. One is the sperm wash, swim up and density gradient method. So among them, what we have to remember is the choice of semen preparation technique. It is based on the nature of the semen sample. So if you have a normospermic patient, you can use either swim up or density gradient. But if the patient is oligoasthenoteratozoospermia, you can use only density gradient. So although density gradient showed to be superior to wash technique or the swim up technique, there is insufficient evidence to recommend any specific method when we are speaking in terms of clinical outcomes after IUI. So the volume of the sample to be loaded is the 0.3 ml. If we inseminate more than this volume, it would lead to reflex of the sample from the uterus. So ideal volume of the inseminate would be 0.3 ml. And before IUI only, we have to note the position of the uterus, uterocervical length and angle must be observed. In cases of acutely anteverted uterus, what we have to do is the partial filling of the bladder, because it will correct the uterocervical angle. Then coming to the one of the important aspect of IUI is technique of the IUI. So for IUI success, so for a simple IUI, what we need is the cusco speculum, powder-free surgical gloves, sterile syringe, Alice forceps, gauze pieces, sponge holder, saline and IUI cannula. So first we put the patient in the dorsal lithotomy position. We should not use any antiseptic solutions. We introduce the cusco speculum. We clean the cervix and vagina with the saline cotton swabs. Then the cervical mucus is removed with the cotton swabs. Then as gently as possible, we will introduce the IUI cannula just beyond the internal os, and slowly and steadily we will push the inseminate for a period of 1 minute. And we will stay there. We should not touch the fundus, and we have to slowly and steadily remove the cannula. So is ultrasound needed? Routine use of ultrasound in IUI is not recommended. But if it is a difficult IUI, we can use ultrasound. So in cases of a difficult IUI, be patient, and then we have to use Alice forceps just to pull the cervix gently, and if the bladder is empty, we have to fill the bladder, and if we want, we can take ultrasound guidance, and then we can use with, if we are not able to enter into the uterine cavity, we can go for a intracervical insemination. Then what is the role of single IUI or double IUI? So these are the ESHRE 2018 guidelines. Women undergoing IUI should be offered a single insemination per cycle. There is no role of double IUI even in cases of unexplained infertility or the male infertility. Then what is the role of bed rest after IUI? Women undergoing IUI should have at least 10 to 15 minutes of bed rest after insemination. Then how many IUI cycles? In couples with an indication of IUI, at least 3 consecutive IUI cycles should be performed. After 3 cycles, there is no substantial increase in the pregnancy rates, but there is insufficient evidence also to recommend maximum number of IUI cycles. Then there is no difference between soft catheter or rigid catheter. And then our cycle cancellation criteria. So if there are more than 3 follicles of 16 mm in size, or more than 5 follicles of 12 mm in size, or the estradiol level of more than 1500 picogram per ml are present, we should cancel the cycle to reduce the multiple pregnancy rates and the OHSS risk. So post IUI, the role of intercourse. Patients, we advise the patient to have the intercourse after IUI if they want to. If the patients, if they feel pelvic discomfort due to ovarian enlargement from clomiphene or gonadotropins, we will tell to avoid the intercourse. Then role of luteal phase support. So particularly if we are using gonadotropin cycles for IUI, we should use progesterone in the form of vaginal progesterone or vodal ritodestrone or vaginal gels. All are equally effective. So finally, IUI can be considered to be cost effective and a non-invasive first-line fertility enhancing technique with fairly acceptable pregnancy rates. So stringent patient selection criteria and tailor-made stimulation protocols with a sound semen preparation techniques all will form the main pillars for the successful outcomes in IUI. Thank you.
Very excellent. Very nice talk, IUI.